several years of research that I've done of disability support workers in Ontario. And just to set the context a little bit for this, I estimate that there are about 35 to 40,000 workers, and they're spread out around 200 nonprofit agencies. These would be agencies that receive 95, 99% of their funding from the provincial government. So it's kind of a broader public sector, but not directly employed by government. The other element that I don't capture in this line of research are a growing portion of the workforce that are hired directly by people with disabilities and families. The government of Ontario, like many jurisdictions globally, have been shifting social service programs to individualized funding arrangements, where rather than contracting with a nonprofit agency to provide services and supports, they'll give money directly to families and people with disabilities to hire their own workers. So I'll mention that a little bit again, but this research is primarily focused on what I describe as the agency-based workforce. These workers provide a range of a variety of supports, residential supports, community integration, employment supports, primarily to people with intellectual and developmental disabilities in Ontario. Contrary to the talk yesterday on Australia, this nonprofit segment is heavily unionized. I estimate that it's about 74% unionized by employee, by the proportion of employees or workers in the sector. The larger agencies tend to be unionized. The smaller nonprofit agencies tend to be non-union. There are many unions involved in the sector, but it tends to be dominated by OPSEU and CUPE. So that's the Ontario Public Service Employees Union and the Canadian Union of Public Employees, and to a lesser extent, the Service Employees International. Quick slide on method. So as I said, this draws from a long-standing program of research I have on the workforce in this sector, including a career and work experience survey that I did in 2018, involving about 3,000 completed surveys. I had the unfortunate luck of launching my psychosocial hazard survey on March 1st, 2020. I got 2 weeks of fantastic survey returns, and then everything crashed with about 1,400 completed surveys. That survey was based upon the Copenhagen Psychological Safety Questionnaire, or COPSOC-3. So it's a well-established survey instrument that I used. And I did it in partnership with the Occupational Health Clinics for Ontario Workers, which gave me the ability to benchmark some of the returns from workers in this particular sector to a Canadian reference group that the health and safety team did with that same survey instrument. The kind of design of today's talk is something of a natural experiment with public health intervention coming during COVID-19. In particular, what I was looking at are the impacts of worksite restrictions. So workers, as I'll show in the data in a moment, tend to work at many different facilities. And when COVID hit, public health said, in order to prevent the transmission of COVID, restrict to a single work site. The other element was known as pandemic pay or wage enhancement. That's the other public health intervention that I'll talk about. Finally, I have a follow-up survey that I draw from that I did this past spring of HR managers in the Toronto and York regions. This involved about 20 agencies, which accounted for about 4,400 workers, or about just over 10% of the workforce. I've changed my presentation a little bit based upon the framework that Dahlia used yesterday, which I think really works well and focuses some of the contributions of what this research stream highlights. In particular, thinking about economic risks and the economic reality prior to COVID, this slide provides job satisfaction ratings across a number of work experience categories, very high rates of satisfaction with the nature of work, with relationships with coworkers and supervisors. But as you can see, very low satisfaction with opportunity, advancement opportunities. So this sense of dead-end careers or dead-end jobs, low satisfaction with pay, and that's fairly concentrated amongst full-timers, less so amongst part-timers, and also some low satisfaction ratings around communication within the organization. But in terms of the economics of it, part of what we see in terms of low satisfaction with pay comes from the employment status. So this is a sector that is dominated by part-time and casual employment. So at the time that I did these surveys in 2018, about 2/3 of the workforce were part-time, and about 17% of those part-timers were fully casual, so no guaranteed hours. Some agencies do provide part-time guaranteed hours, but many of them are fully casual. In terms of the makeup of the workforce, these surveys, I generally do the entire workforce. So the frontline positions are classified as direct support professionals, but I also captured data from supervisors, managers, specialized professionals, and others. But my talk will focus on that bulk of the 77% of the workforce that are the direct service professions. So this is a quote that I think captures some of the aspects of economic risk. And what I want to draw your attention to is a couple of aspects of this quote. This is from an open-ended question in that 2018 survey, basically saying the big problem, and this respondent felt that the people served would benefit. The big problem was the need for more full-time staff compared to part-time. And without any of the data that I have, the staff member made the observation that part-time staff need to have 2 or 3 jobs just to make ends meet. And that certainly was borne out by the survey responses. And so this chart compares the broader segment of health and social services. So these are data collected by Statistics Canada on multiple job holders compared to what I found in my own survey. So in that broader segment of health and social services, Stats Can had about 8.4% of the Ontario workforce holding multiple jobs, but that spiked up to 42% in my sample in respondents. So a large swath of the workforce holds multiple jobs, and it also provided, I think, some evidence that the part-time positions are involuntary part-time positions rather than preferential positions. And I had other data points to confirm that, but again, this multiple job holding aspect has been a deeply entrenched and highly problematic aspect of the quality of work in the sector. Where do people work? And this links back to what I was saying earlier about the rise of individualized funding. So of those surveyed, fully 1 in 5 work directly for a family or for a person who receives those individualized funds. So a lot of growth in this totally unregulated segment of provision of services and supports. Fewer people worked outside the sector. A number of people, just over 10, 15%, not quite 15%, worked at multiple agencies. And that would tend to happen at the large metropolitan centers like Toronto and York and the like. Next, I want to talk a little bit about psychosocial factors. So thinking about aspects in part around autonomy, but also around recognition, around aspects of meaningful work. And again, this is based upon the COPSOC-3, the Copenhagen Psychological Safety Questionnaire. And what I found was interesting contradictions in the nature of this work. So what these charts show are the comparisons between the responses from my survey against the Canadian benchmark of generic workforce. And so I was able to show, well, what kind of rate of hazards are workers in this sector experiencing compared to the Canadian reference group? And the degree of emotional demands in this work are much more acute than the Canadian workforce as a whole. So 41% experiencing much worse emotional demands, much higher rates of emotional exhaustion, overall 70% higher than the Canadian benchmark. At the same time, however, workers reported more meaningful work than the Canadian reference group. So you have much more emotionally demanding work on the one hand, but work that this workforce tends to describe as highly meaningful. So you have that, that kind of contradictory nature within psychosocial hazards. The other aspect around psychosocial hazards that was another seeming contradiction, and this reflects that low rate of satisfaction for possibilities for career advancement, was having a much lower sense of possibilities for development compared to the Canadian reference group. So again, almost 49%, 50% feeling that their opportunities for advancement are worse than the Canadian reference group, but still very committed to the workplace. And this, I think, reflects the nonprofit nature of very value-based, mission-driven organizations working towards making the lives of people with disabilities more inclusive. So it's very much driven by that kind of pro-social motivation or pro-social sense that I work for an organization that in which the work is meaningful and in which the goal of the organization is valued, even if I can't advance in my career. Within this context then, so that was surveys from 2020, we see the public health interventions coming as a result of COVID-19. And there are two aspects to this I want to highlight. The first one is a bit dense, but this is a memo from one of the employer associations distilling what the medical officer of health directives in April 2020 meant for the operations of these nonprofit organizations. In the first instance, it may seem to be kind of anti-union. It gave broad powers for employers to ignore terms of the collective agreement in order to respond quickly. And generally speaking, this wasn't received in an adversarial way. The employers worked with the unions, in part because we saw redeployment of staff at the level of 60 to 70% of staff having to be redeployed. They were considered essential workers, so they still had to provide 24 hours, 7 days a week supports. But this allowed organizations to do things that they would not otherwise be able to do in order to alleviate the outbreak of COVID-19. And in particular, what was interesting that this sector, unlike the long-term care sector, there was not a mandate to restrict work at one facility. However, the employers tended to adopt this as their own practice. So the long-term care facilities serving the elderly population tend to be a little bit siloed from this subsector, but the employers adopted those same practices. Here we see that same memo offering in suggestions that, well, let's incentivize staying to work at one work site by increasing wages, by increasing hours in particular, and creating more full-time jobs. And that was the impact that this public health intervention had on this workforce. So then it became the question of, well, did it really? And so when I did the survey this past spring, again, this was a smaller sample just of HR managers, but I think it's reliable data. 30% of them said there are now significantly more full-time jobs in those frontline positions than pre-COVID, another 25% slightly more. And the data would suggest that the 2-to-1 ratios were flip-flopped. So now the majority of the workforce, at least at this point in time, are full-time, and you have a much smaller proportion that are part-time. Now that's somewhat deceptive, or not somewhat deceptive. It somewhat hides the fact that within this context, you have a much tighter labor market as the economy emerged from COVID restrictions. So part of this is driven by tight labor markets, and at the same time that they've created more full-time positions, agencies in my survey sample are using. They're covering about 17% of their service hours through temporary help agencies. So they've made their core staff more full-time, but now they're more reliant on agency staff in some ways. So it's a mixed message there. Pandemic pay, and that's the $3 an hour wage enhancement, was made permanent to these workers. So unlike in some other industries like the grocery sector, workers in this sector, workers in the long-term care sector, saw that those wage enhancements were made permanent as of July 2022. And it's $3 an hour on what was an average wage of about $24, $25 an hour. So more than a 10% wage increase. And just to put this in context, that's a larger wage boost than most workers in this sector have been able to collectively bargain over the last 10 years. So this sector struggles to achieve 1 or 2% wage increases in bargaining. Why? Well, these are nonprofit organizations, and collective bargaining doesn't happen with the funder sitting at the table. So managers are bargaining without any means to increase their revenue or increase what they can charge government for the provision of these services. So this was a major change in terms of the economics. So what does this mean in terms of what I draw from this? One is kind of an affirmation that this public health directive, although perhaps unintended in its consequences, did certainly have a positive impact on work in this sector. It's somewhat difficult to disentangle the labor market effects from the public health directives, but what is clear to me is the reduction in full-time work is real. Now, whether it's sustained over time, I think is a real question, financially and operationally. That's why nonprofit organizations relied so heavily on part-time workers, and I would expect to see slippage over time back into those previous models. But the other highlight that it shows in terms of the trade-offs of risks, direct support workers traded control of working time. So you hold 2 or 3 jobs, but the advantage for workers there is that you could refuse shifts. You can say, no, I have some control of when I work. When you take the full-time position, you lose some of that freedom in terms of refusing evening or weekend shifts. And so you have that economic risk trade-off of control of working time for enhanced economic security and employment stability. The other, I think, important contributions that this case makes to our stream on the experimentation and the ways that work can be made better are looking at the psychosocial risks and the trade-offs that workers already make between finding the work very meaningful and the emotional demands and the emotional exhaustion that plays into it. And we heard it a little bit with the telecom, but I wanted to really drive this point home in terms of how do we think about those trade-offs? Is it really is important to think about the quality of care outcomes? In other words, do the workers feel like the people who receive their services are having a better life as a result of the services provided? So it's that relationship with the end user, with the service user, that is in part shaping the experience of the quality of work in this sector. If they're working for an organization that doesn't have the resources to make truly person-centered approaches to supports and services, or if the organization has kind of mindset that simply treats people as, here I'm talking about the people supported as numbers to be managed rather than people to be supported, that trade-off fails to meet that kind of meaningful work with the emotional demand trade-off. So the quality of work is linked to the quality of care outcomes.